I want to introduce Dr. Harish Raulapalli, MD and DM, Professor and Chief Cardiac Anesthesiologist, Narayana Medical College Hospital, Nellore. He is going to take master class on physiology of cardiopulmonary.
We lost you. I lost you.
Hello.
Yeah, please go on.
Yeah, Dr. Harish Raulapalli is going to take master class on physiology of cardiopulmonary bypass. His areas of interest are trans-esophageal echocardiography and complex congenital cardiac anesthesia. He has total number of publications, 12 he is having. He has achieved Janak Mehta Best Scientific Paper Award in 2010. Executive Council member for IACTA. He is from 2018 to 2022. He is reviewer for American Journal of Case Reports and World Journal of Cardiovascular Surgery. Our today's second speaker is Dr. Apex Patwa. He is Chief Consultant Anesthesiologist, Kailash Cancer Hospital and Research Center, Vadodara Institute of Neurological Sciences, Vadodara. He is going to speak on equipment of the month, video laryngoscope. He is the right person to teach us all about video laryngoscope, since he has designed and developed Patwasha's one video laryngoscope and HU flow to HFNO device. He is author of IDA consensus guidelines for airway management in OR during COVID-19 and pandemic 2009. Also co-author of IDA difficult airway guidelines of 2016. He is the winner of ISA Academic Excellence Award in 2017. He is course director of IDA Fellowship Advanced and Difficult Airway. He has 3 national awards, 12 publications, and he has written 5 chapters in different books. Today we are going to have one case discussion session, which is on ischemic heart disease coming for patient with the ischemic heart disease coming for CABG. Moderators for the case presentations are eminent faculty such as Dr. Sanjay Kumar Banakal and Dr. Sharanagowda Patil. Dr. Sanjay Kumar Banakal is Senior Consultant Anesthesiologist in Narayana Hrudayalaya Institute of Medical Sciences, Bengaluru. He is Senior Consultant Anesthetist, also worked in Manipal Heart Foundation, St. John's Medical College, BM Birla Heart Research Center, and Kasturba Medical College, Manipal. He has done his MBBS from JNMC Belgaum and MD from Kasturba Medical College, and postgraduate diploma in hospital and healthcare management from Indira Gandhi National Open University, New Delhi. Our one more moderator for today is Dr. Sharanagowda Patil. He is professor and HOD of Department of Cardiac Anesthesia in JNMC Belgaum. He has done his MBBS from Al-Amin Medical College, Bijapur, MD from KMC Manipal, and PDCC from SRMC Chennai. He is working in JNMC Medical College since 2003. These faculties for this session, and we have case presenters Dr. Neha and Dr. Sisla from KMC Mangalore. So welcome you all of you for today's session. Have a nice session. Nice. Shipat sir.
Thank you, Dr. Murli.
Yes.
For this brief introduction. Again, I welcome everyone. Unfortunately, due to situations unforeseen situation, Dr.
Mahesh.
Dr. Mahesh Wakamudi could not be part of the program today. So, Dr. Harish Raulapalli has graciously accepted our invitation, and he has rushed through to prepare and present excellent topic for the day. We are much obliged to Dr. Harish for this great adjustment, and we anticipate excellent discourse from you, Dr. Harish. Thanks for joining us and agreeing to do the topic in such short notice. Stage is yours.
Thank you, sir. Actually, pleasure is all mine. And I thank Dr. Sripada sir and Dr. Murali and the entire faculty of KS Medical College from Bangalore for having me for this topic. So I request all of you to keep your mics on mute so that there won't be any disturbance for us. So you can ask me any question at the end of the session regarding this topic. Can you see my screen, full screen? Can somebody respond?
Harish, yeah, please go ahead.
Yes, we can see it.
You can see not only your screen, your heart is also beating.
Thank you, sir. Thank you. So nice of you. Yeah. Coming to the topic. Yeah, as sir told, this topic has supposed to be delivered by one of the greatest cardiac anesthesiologist and my teacher, boss, mentor, everything for me. Who whatever cardiac anesthesia I learned is from him. So I know it is very difficult to fill his shoe, and it's it's almost impossible to match his knowledge because I've seen him from for the 5 years, very close to him, working with him. So, but I promise that I'll try to do some justice to this topic. So, thank you, sir, for having me this once again. So, coming to this topic, so it's not very uncommon to see this scenario once the patient is on bypass, right? I think if any cardiac anesthesiologist over here can understand this. So once the patient is on bypass, so we, or at least some of us, we feel that it is the job of
surgeon would positive.
So, yeah, I once again request, please keep your mics on mute. Yeah. So we think that once the patient is on bypass, it's not our role. It is the role of the perfusionist and the surgeon to do rest of the things, but it's not so, because for the simple reason, if you take one cardiac surgery, which is done on open heart surgery, for example, if you take a mitral valve replacement, the total duration of the surgery for a reasonably fast surgeon will be around 3 hours. So out of 3 hours, around 1 hour, 10 minutes will be, the patient will be on bypass. So in that crucial time, if we don't focus on the patient and what is happening to his physiology, so patient will be in a lot of trouble post-operatively, because in the ICU, it is you who has to see the patient. So it is our job to have concentrate on bypass, see what the perfusionist is doing and look at the physiology and do some corrections and advise the perfusionist and try to also advise the surgeon if necessary, if there is any problem, because the surgeon will be busy with his procedure. Okay, like, so it is quite common that we compare ourselves, anesthesiologists, with the eagles. Like, you should have a eagle kind of a eye, so you should catch everything, and you should always try to prevent any unforeseen events, right? So here the quote says, have an eagle eye, because people changes faster than sky. Okay, let us slightly modify this phrase, take out people, so add hemodynamics. So have an eagle eye, because hemodynamics changes faster than sky when the patient is on bypass, if you don't concentrate on the patient, if there is some problem. Okay, So with this introduction, we'll go to the topic. So the first of all, why this topic at all? Why this lecture? Why should we know about this? Okay, I think we'll find the answer to this slide at the end of this talk. Okay, so coming to the lecture outline, broadly we'll do it in under 3 headings. To start with, I'll take out the history because I've not added the history because it looks very lengthy. So indications of the bypass, what are the basic circuit components, how actually cardiopulmonary bypass circuit looks like that, what are the components, then followed by what are the checklists for the patient to have to go before on bypass and on bypass, and what is the checklist of the patient is supposed to wean from bypass, and some physiology regarding temperature, hemodilation, anticoagulation, what should be the pH strategy. So, and finally, what are the complications of cardiopulmonary bypass. So we'll discuss these three, discuss the things under these 3 headings. Okay. So to start with, so cardiopulmonary bypass, it's a technique in which a machine temporarily takes over the function of the heart and lungs during the surgery, maintaining the circulation of the blood and oxygen content of the patient's body. So it's simply that we bypass the lungs and the heart. So the function of the heart and lungs are taken over by this cardiopulmonary bypass. Okay, so that the circulation and the oxygenation and the circulation are taken on by this cardiopulmonary bypass circuit. Okay, so what are the major functions? The oxygenation and CO2 elimination, that is the ventilatory function. Then the circulation of the blood, the cooling and rewarming, because the surgeries on bypass are done under some amount of hypothermia, and to provide a bloodless surgical field, because one of the main important purpose of this bypass is the surgeon to have a bloodless surgical field so that the repair should be very optimum and patient will have a very good outcome. So these are the major functions of the cardiopulmonary bypass. So what are the indications? We know any cardiac surgery which requires the opening of the heart, for the simple, to put it simple. And there are different types like supportive bypass and partial bypass. When you don't cross-clamp the aorta, we call it as a partial bypass, and left heart bypass, like that, and so on. And most of the congenital cardiac diseases, like they need intracardiac repair. So you need a cardiopulmonary bypass support. So there are some non-cardiac surgery where you occasionally you can use cardiopulmonary bypass, like thoracic surgeries like arch aneurysms and renal cell carcinoma, where extensive invasion into the IVC, and some tracheal reconstruction surgeries, and some liver transplants. So these are the areas where non-cardiac areas where you can use cardiopulmonary bypass. So coming to the major components of the bypass, that is a pump. So that what we compare with as a heart, and an oxygenator that is compared with the lung, a reservoir which takes out all the blood from the patient, receives the whole of the blood from the patient, and then heat exchanger to cool and warm the patient and the blood, and the circuit and other cannulas required to cannulate the patient. Okay, these are the major components, and some minor components, because like an anesthesia workstation, the cardiopulmonary bypass will have a lot of safety features to avoid any accidents. Like so many minor components add to this to prevent any accidents and to assure the safety conduct of cardiopulmonary bypass, like filters, sensors, cardioplasia, delivery system, and so on. Okay, so look at the components. So we'll have the venous reservoir and the oxygenator and the heat exchanger. So these 3 can be separately you can use, but most of the systems now they come as an incorporated system, like on a single component, like the venous reservoir, which receives the venous blood from the patient, the oxygenator, which oxygenates the blood, and the heat exchanger. On the other side, you can see a pump, that is a roller pump, which actually pushes the blood to the patient and receives the vent cardiotomy suction from the patient. And the other top, you can see top right, it is a circuit, like the components, like the tubings with various diameters, Okay, see, these are the major components of the cardiopulmonary bypass circuit. So the pump shown here is a roller pump. We'll go into the details later. So to have you an idea of what is actually cardiopulmonary bypass circuit, how it actually works. So I'll try to explain with this small animated video, okay? Yeah. As I told, the venous blood is taken from the patient into the venous reservoir. Okay, by SVC and IVC, there will be the surgeon cannulates the SVC and IVC, and entire the venous blood is taken into the venous reservoir. From the venous reservoir, it goes to the roller pump. From the pump, it goes to the oxygenator, where the blood gets oxygenated. And meanwhile, as there is an added component of heat exchanger, so the blood will be heated or cooled according to the situation, like whatever temperature you need, what kind of hypothermia you are planning. So according to that particular temperatures, the heat exchanger will cool or warm the blood. On the other side, the oxygenator gets the oxygen from a oxygen blender, where it is you have a blender which mixes the air and oxygen. So required amount of FiO2 and amount of gas flow can be controlled from this blender, and thus that will be added to the oxygenator. Okay, so once you add the gas, that is oxygen, to the oxygenator, so the amount of the PO2 and the gas flow will be controlled by this blender. From the oxygenator, the blood goes to the patient's aorta through an arterial filter. So the arterial filter is to avoid any bubbles or any microemboli, so that because this blood directly goes to the patient, so you should not have any foreign material. So from oxygenator, the blood directly goes to the aorta through an arterial filter. And on the other side, some of the blood from the arterial line can be taken into the cardioplasia delivery system, and through another separate pump, this delivery system mixes the cardioplasia blood with the crystalloid and prepares the cardioplasia, which can be delivered to the heart to make the heart arrest. Okay, that is a part of the delivery system. So once you cross clamp the aorta, that cardioplasia will be given to in the root of the aorta. Through the coronaries, it distributes to the myocardium, and heart gets arrested in the diastole, so that you will have a still blood field, okay, non-beating heart. Okay, on the other side, throughout the surgery, because the heart have other sources of blood supply, so there will be some amount of blood coming to the ventricles, left ventricle. So that will be taken back into the reservoir through a vent. On the other side, the cardiotomy, whatever blood that is oozing through the thoracic cavity into the field, that is called as a cardiotomy. That blood also will be added to the reservoir. So this completes the basic circuit of a cardiopulmonary bypass. Okay, so there are roller pumps, a reservoir, an oxygenator, a heat exchanger, and a cardioplasia delivery system, a vent, and a sucker. And this is how the cardiopulmonary bypass circuit looks and runs. Okay, so with this, we'll go to individual components of the circuit. Actually, how they work and all. Some major components we'd like to describe the individual components. As I said, one of the important component is the pump. That is the heart of the CPB circuit. So there are different pumps like roller pumps and centrifugal pumps. So most commonly what we use is roller pumps. So this is the technology used in roller pump. So there are two rollers which are placed 180 degrees opposite, and through the roller, the circuit passes the tubing. Inside the tube, there will be passage of the blood. So the blood flow should be equal to this pump has to produce a pressure to provide a blood flow against minimal resistance. Okay, so that is the function of the roller pump. That is how it actually works. So the amount of rotation or revolutions per minute will be directly proportional to the flow. If you want to increase the flow, you just increase the revolutions. So that's how you control the flow. So as you increase the flow, the pressure also will be increased, or the mean arterial pressure. So on the other hand, there are other types of pumps called centrifugal pumps. Here, the blood is taken into a centrifugal cone, and in between there will be fins. So through the fins rotation, the blood will be pumped to the patient. So here, these pumps are mostly afterload dependent. Okay, so but most commonly on CPB circuit, the kind of pump we use is the roller pump. Okay, so if you look at the major differences between these two pumps, roller pumps are all afterload independent because the flow is controlled with the rotations. Here, centrifugal pumps are afterload dependent. If the patient has severe very high systemic vascular resistance, the pump flow can be compromised. So on the other hand, roller pumps, as you have seen, there will be a possibility of little trauma at the high flows, and they are little bulky compared to centrifugal pump. And mostly the roller pumps are used for short-term use. On the other side, centrifugal pumps are used for the long-term use. They're very portable. And so long-term use, like when you plan an ECMO for a long-term, when a patient is with a severe heart failure, waiting for a transplant, suddenly crash. So you need to put him on ECMO. So then the centrifugal pump is the ideal one to use. Okay, so that is the kind of use and differences between these two pumps. So coming to the another component, oxygenator. So we have basically three oxygenators, three types: the disc oxygenator, bubble oxygenator, and membrane oxygenator. The first two are not in use now. Most of the oxygenator, or almost all oxygenators, are in current use are membrane oxygenators. Okay, so if you look at the membrane oxygenator, there are different types: scrolled envelope, parallel plate, or hollow fiber type. Okay, these are the different materials used, but commonly used material is polypropylene. Okay, so again, the commonest oxygenator type what we get is hollow fiber type. In hollow fiber, you can see here hollow fibers. Okay, either the blood will be inside the fiber or outside. So there will be a thin membrane, okay, which separates the gas from the blood. Okay, so if you look at the working principle, this is one of the type of the hollow fiber oxygenator. Here the gas enters in the center. Okay, see, that's how the gas enters. So in between there is a heat exchanger here. Unlike the previous one, what I have shown, here the heat exchanger is in the middle. Okay, so just adjacent to that, there will be a gas flow. Okay, so what he is showing is that is the water inlet and outlet to warm or cool the blood. So then the blood gets entered and slowly dissipates. So initially, when there is a contact between the blood and gas, there will be immediately formation of some protein membrane. So across that membrane, there will be a gas exchange which occurs inside the oxygenator. That is the working principle. Here, the important thing here, we can control the FiO2, the PO2s by adjusting the FiO2 by using oxygen blender. And we can control the CO2 elimination by adjusting the gas flow. Okay, so there is a difference. To control the PO2, we need to adjust the FiO2 on the blender. And to control the CO2 elimination, we need to adjust the gas flow. That is called sweep gas flow, which is entering into the oxygenator. So that's how actually basically these oxygenators work. So gas exchange occurs with the principles of like any other principle, like diffusion, convection, chemical reaction. These are the three principles actually which are applied inside our lung. The same applies here also. But compared to our lung, this is not that efficient because the diffusional distance is very high. Here it is almost 200 micrometers, whereas in our lung it is only 10 micrometers. So the blood has to travel so much distance to get diffusion. And the surface area of this oxygenator will be 1.7 to 3.5 micrometers versus 70 to 100 micrometers. So the surface area also very less compared to our lung. So that is the reason it is not very efficient like our lung.
Hello.
But, yeah, but it serves the purpose. Okay. So coming to the reservoir, there are different types like open reservoir, closed reservoir. This reservoir, as I have shown you, placed immediately before the arterial pump because the blood comes immediately and through the pump it goes to the reservoir. Okay. So it is of high capacitance, low pressure chamber. So most of the blood from the patient gets drained into the reservoir by gravity dependent drainage. So that's why it is very important when the patient immediately goes on bypass, you need to check the level of the table so that if the table is not adequate height from the reservoir, so the drainage will not be efficient. Okay. So the reservoir not only takes the venous return, but also takes the blood from the vent, cardiotomy, and there are small ports will be there where you can add your anesthetic drugs and other things. So that is the function of the reservoir. Coming to the Cardioplasia delivery system. So these are the different delivery type of systems we have. Like a entire major component, the Cardioplasia delivery system also should have a facilitation for the warming and cooling of the cardioplasia. Oh, okay. So then there are different types of delivery, antegrade and retrograde, and composition, like some use cold cardioplasia, some use warm, but most of the times it will be cold cardioplasia. The temperature will be between 4 to 7 degrees centigrade, and it will be a pure crystalline and blood. So usually it is a mixed, it's a 1:4 ratio. So, and composition also differs. There are different types of cardioplasia solutions. I'll show you. So that's how it things. So antegrade cardioplasia means you give the cardioplasia through the this cardioplasia cannula. So here, this is you cross clamp the aorta here. So above that, there will be a aortic cannula where you perfuse the entire systemic circulation. So below the cross clamp, there is one more cannula. This is the cardioplasia cannula. So you deliver the cardioplasia through this cannula. From here, they go into both the coronaries, and the entire heart gets the cardioplasia and gets arrested. So this is called antegrade cardioplasia. Other one is retrograde cardioplasia, where another special cannula, you open the right atrial appendage, and through the right atrium, you push this cannula into the coronary sinus and you deliver the cardioplasia. So these are the two types of the delivery of the cardioplasia system, that antegrade and retrograde. So coming to the compositions of cardioplasia, as I told, there are different solutions, but most commonly what we use is extracellular cardioplasia solutions like St. Thomas solutions. So these are the different components and composition of the cardioplasia system. So usually once in every 20 to 25 minutes, we will be repeating the dose of the cardioplasia. So usually they'll give 10 to 15 ml per kg at 4 to 7 degrees centigrade with the minimum of the potassium, very high potassium, around 20 milliequivalents per liter potassium should be there. So that is a major component of the cardioplasia to arrest the heart in diastole. Okay, so coming to the other important component, heat exchanger. So as I told you, it is the lowermost component in the system where blood enters through this, and there will be a coil-like structure in the middle, and on the other side there will be water inlet and water outlet. From here, the blood will be inside this coil, so water will be above that. So depending on the temperature of the water, the blood gets whether it is warmed up or cooled up, depending on what kind of water temperature we are giving through this inlet and outlet. Okay, so that's how you control the body temperature But usually that principle is like surface heat transfer. That's how the heat gets transferred from the water to the blood. So most important thing is you should maintain a gradient of around at least 10 degrees centigrade between the patient and this temperature, heat exchanger temperature. So rapid cooling can be rapid because 1 degree every 1 minute you can cool down. But while rewarming the patient, you should be very careful because there is once the temperature increases, the gas solubility comes down and there will be a formation of the bubbles and there can be a chance of cerebral injury and protein denaturation. So most importantly, cerebral injury, because when the temperature goes beyond 40 degrees, if you don't notice, there will be injury to the brain. Okay, so as I told you, so conduction of CPB can be compared with a plane, a perfect takeoff, what we call, and a non-turbulent flight, followed by a smooth land. So these, how we can compare this? The perfect takeoff is like before going to bypass, you should have a good checklist without any problem. Like smooth landing of this plane with a good checklist without any problem, you should wean the patient from the bypass. Okay, let's go and see each stage. So to start with, there are 4 stages, okay, to go on bypass. First, you assemble the circuit and you check the checklist, whether everything is proper. Then everything is okay. You start the bypass. That is, the patient will be on bypass. Then you maintain the bypass. You check the parameters. Again, on bypass, there will be a checklist. So what are the checklist? We'll see. Then you maintain the bypass with that checklist. Then once the surgeon finishes his job, then you will wean the patient from the bypass. Okay. So you assemble the circuit, the first, then bypass checklist, everything is okay. Put the patient on bypass, check the parameters, everything is okay. And you give the cardioplasia, stop the heart and lungs, and continue the bypass. On the other side, again, there are 4 steps weaning from the bypass. Once everything is done, restart the heart and lungs after rewarming the patient. Then check the parameters. Again, what are the parameters we have to see? I'll let you know. Then you have a on bypass checklist, that is before weaning the checklist. Then followed by, if everything is okay, stop the bypass, that is put off the bypass. And finally, dismantle the circuit. This is how it goes. So each one and each of the stage will go one by one. So assembling and priming the circuit. Okay. So the basic idea of priming a circuit is we need to de-air the entire circuit and all the components, which I have shown: the reservoir, the oxygenator, the heat exchanger, everything should be de-aired. Okay. So you cannot have an empty circuit connected to that. So that to de-air, we need to put some amount of fluid. Okay. So that is called the priming volume. So usually it will be around 1 to 1.2 liters. Okay. So depending on the patient's hematocrit, baseline hematocrit, sometimes we may add blood to the priming fluid, sometimes we may not. And most of the times it is only crystalloid prime. You should not add any colloids from the recent guidelines. It is only a crystalloid prime. So usually when you add some 1200 ml of crystalloid solution, there will be drop of hematocrit to the up to 1/3 of the patient's baseline. So that causes a decrease in viscosity. So usually what you observe when the patient is on bypass, immediately there will be sudden fall in the mean arterial pressure. So this is the reason, because immediately the blood gets mixed with this 1.5 liters of priming solution. There will be drop in hematocrit, the mean arterial pressure falls. So the pressure will be low. That is immediate, but slowly it gets corrected. So apart from adding heparin to the patient, so the perfusionist will add some amount of heparin to the bypass circuit, usually 3 to 4 units per ml, to prevent any untoward incidents. Okay, so there are formulas to see what is the actual hematocrit required for that particular patient, and what should be the target for that patient, and how much blood to be added to the prime. So based on these calculations, the perfusionist in conjunction with the anesthesiologist will decide how much blood to be added to the prime if required. So as I told, we have a pre-bypass checklist. Okay, so these are the 8 parameters we should check before you go on the bypass. So anticoagulation, arterial cannulation, venous cannulation, and so one by one we'll go and see. So anticoagulation, heparin is the major anticoagulant we use, and very high doses we use, that is 300 to 500 units per kg, so 3 to 4 mg per kg. So, and it should be checked with the point of care test, that is ACT. So if the ACT is more than 300 seconds, then you can ask the surgeon to cannulate. And for CPB, you should have at least 400 seconds of ACT. The safe will be more than above and around 480 seconds. So for every half an hour, you should be checking this ACT. If the ACT comes down below 400, you will be adding the heparin to the bypass circuit. So there are issues like some patients will have heparin resistance, whatever amount of heparin. If after giving up to 800 to 1000 units of heparin, if you are not able to achieve the target ACT, we call it as heparin resistance. There are various reasons, like patients who are on nitrates, and patients who are on chronic diseases like renal disease, they'll have some kind of heparin resistance. In those scenarios, you need to add some amount of fresh frozen plasma to the patient. Then the antithrombin level gets corrected, and you can get back the desired ACT. So another phenomenon is heparin rebound after the cardiopulmonary bypass. Whatever heparin is required, when left with the patient, may rebound in the post-operative period. That may cause increase in bleeding. So according to the recommendations, the ACT should be around 480 seconds to go on bypass. That is class 2A recommendation from the European societies. So anticoagulation is done. So next, arterial cannulation. So most common site of cannulation is distal ascending aorta. Okay, you can see here the patient, the surgeon just opens the aorta, gives a small nick, and puts the aortic cannula inside. Slugs the cannula and slowly open the cannula to de-air the cannula, and he connects the cannula to the arterial side of the cardiopulmonary bypass circuit. So he's just tapping to de-air the cannula and slightly open so that you completely de-air the cannula, because you should not have any amount of air in that. So you ask the perfusionist to run the pump gently. So he runs, then immediately you connect the cannula so that there should not be any entry of air. That's how the arterial cannulation is done. Anytime, any bypass, it is the first, aortic cannula is the first to be done, not the venous cannula. Okay. So there is a very rare complication of aortic dissection, very rare. And there is a perioperative stroke. If the aorta is bad, it is calcified, a lot of atheromas. So all those problems can occur. So followed by aortic cannulation, we'll have a venous cannulation. So venous cannulation can be either single stage cannula like this. What you have a single cannula will be putting in IVC and through the RA, or double cannula, like two separate cannulas, one in the SVC, one in IVC. So this depends on what kind of surgery you are doing. If the patient requires that the right heart to be opened, then they use two separate cannulas. And if some surgeries like CABGs, on-pump CABGs, where you don't need to open the heart, you can do with the single cannula. So that's how he is taking the IVC pulse string. Just take a pulse string, give a small nick, and push the cannula inside and snug the cannula. So once everything is done, both the cannulas will be connected to the other end of the cardiopulmonary bypass circuit. Okay. So anticoagulation is done, aortic cannulation over, venous cannulation over. If you have any PA catheter inside, you have to pull it back before you go on bypass. And you have to check all your monitors. So you adjust your monitor settings because you are going on bypass. So you need to put them on silent mode. And if you are using a TE probe, it should be in the freeze mode because you are not going to use during bypass. So to avoid any thermal injuries, you have to put the TE probe in freeze. And then supplemental medications, anesthetic drugs. Okay. So there will be a significant change of pharmacokinetics and dynamics of these our anesthetic drugs. For the reasons being, one is because of hemodilution. Because of hemodilution, there will be reduced plasma protein concentration. And there will be hypothermia-induced altered drug clearance. Okay. And the drug sequestration in the lungs. These are the 4 reasons for the altered pharmacokinetics and dynamics. So volatile agents like usually hemodilution and hypothermia, they will be counterbalance each other because the blood gas partition will be high and there is a hemodilution, and hypothermia it will be low. So lower requirements will be needed during hypothermia, and during rewarming you need little higher doses, but that gets corrected once the patient comes to the normal temperature. Okay. And if you are using a vaporizer to the CPB circuit, so you need to measure the vaporizer concentration and by using a separate line which is connected to the oxygenator. Okay, coming to the IV agents, mostly the protein-bound drugs like propofol and opioids, because of hemodilution, large amount of unbound drug will be available because the proteins gets diluted. Their effects will be potentiated. And important consideration is remifentanil. You need to almost decrease 50% of the dose of the remifentanil if you are using on bypass, because its elimination is on temperature-based elimination because you are going to cool the patient, so it gets prolonged. So you need to completely cut down the dosage of remifentanil. So neuromuscular blocking agents, mostly earlier we used to use pancuronium, but because of pancuronium long-acting agent, and we don't know exact duration, so there will be possibility of awareness. So now they recommend use of the short and intermediate acting agents on bypass. So you can use vecuronium or etracurium. Another problem with etracurium and rocuronium is little high incidence of allergic reactions on bypass. So probably vecuronium comes as a safer agent. So we have added supplemental medications. And finally, when you just go on bypass, you need to look at the face of the patient, because when the aortic cannula is put, if the tip of the aortic cannula is not directed into the center of the aorta, or if it is directed one of the major branches of the head and neck vessels, so there will be unilateral flow to the brain. So that may cause the unilateral swelling of the face, facial edema, conjunctival edema. So you can just check the face. So make sure that nothing of that sort has happened. Okay, so that we complete the pre-bypass checklist. Now we are ready to go on bypass. Okay, once you are on bypass, there is on bypass checklist. So first you need to assess the arterial inflow. So what is the once you remove the arterial clamp, when you look at the color of the arterial blade, whether it is properly oxygenated in the oxygenator or not, then check the venous flow, because both the venous cannulas are in the venous side, like IVC and SVC. So surgeons will be sometimes constantly manipulating the heart. So that may cause or impede the venous return. So you need to constantly look at the venous reservoir for the proper drainage of the venous flow. If anything like that is there, you need to alert the surgeon so that they will readjust the venous cannulas. Then look at whether bypass is complete or not, because you have a proper arterial flow, proper venous return, and good arterial oxygenation. There is no problem. Okay, and then discontinue the drug and fluid administration. So whatever IV fluid if you are giving, you need to stop, and you need to stop all other drugs, and you need to stop the ventilation. And if you have inhalation agents, you need to stop. But here, instead of completely stopping the lungs from the ventilator, so there is a practice that we use very small tidal volume, like around 50 ml, and a very small rate around 9 to 10, so that you prevent the atelectasis of the lungs. So that won't cause any problem to the surgeon or surgical field. So you can have very small tidal volume, very low rate, prevent the atelectasis. So you check everything on bypass. So everything is okay. You maintain the bypass. Okay. So coming to the physiology of the bypass. So far we have finished we put the patient on bypass. So bypass running. So let us see what physiological derangements will happen on bypass. So there are the 4 things which we need to mention: the perfusion pressure and pump flow, hemodilution and its effects, the hypothermia and its effects, and how you are going to manage your acid-base status on bypass. So that, because these are the things which will actually decide your physiology of the patient. So to start with perfusion pressure and pump flow. Perfusion pressure, it is like low flow, low pressure versus high flow and high pressure. So if you are using a low flow and low pressure, so that will be good for the surgeon, because you will not have much of the blood in the field, the pressure will be low. And if you are using high, but it is bad for the patient, because there may be ischemia, enough pressure is not maintained, and there will be oxygen, arterial oxygen content because of the low flow. On the other side, if you use high flow and high pressure, which is good for the patient, but bad for the surgeon, but he may not like, because there will be surgical flooding of the surgical site. So you need to balance this, selecting particular flow to the particular patient. So there can be a possibility of hypotension, and most commonly because of some reason, like the patient pre-operatively, if he is on very high dose of antihypertensives, okay, or vasoplegia on bypass, or severe inflammatory reaction. So that may cause hypotension. So you can use small dose of vasopressors. Hypertension, most commonly lower doses of the anesthetic agents or lighter planes of anesthesia may cause the hypertension on cardiopulmonary bypass. Okay, after supplementing the drugs, still if the pressure is high, you can use a vasodilator to decrease the pressure. So coming to the guidelines, how much to use, what pressure to target? They say that it should not be more than 80 and it should not be less than 50. So somewhere between 50 to 80. So ideally what they say, most of the books or most of the literature, beyond 60 years of age, you target the pressure of a age. If the 65, so you target 65. So if below 60, the ideal pressure will be around 55 to 60. That is the pressure maintained on bypass. Okay. And another thing we need to have keep in mind here is not everybody will have same pressure target. If you have a patient with hypertension who is untreated, and his target mean arterial pressure should be higher, because he requires higher pressure to maintain the perfusion. So like that, you need to think about that particular patient and you need to set the target. So ideally it should be between 50 to 80. So beyond 80, the patient may not require, and studies have shown that it's not good to have higher mean arterial pressures on bypass. Okay. So pump flow. So how do you decide how much flow for this patient is? It depends on that particular patient body surface area and cardiac index. Okay. So and temperature. So what temperature you are going to cool the patient? Depending on that, these are the required flows to be maintained on bypass. So coming to the guidelines, they say that earlier we used to think only about the body surface area and cardiac index, but we need to temperature also we need to take into account when you are deciding what should be the flow of that particular patient on bypass. So that is what the guideline says. So coming to the hemodilation. So the immediate effects of the hemodilation are there will be a decrease in viscosity and decrease in hematocrit. So that will lead to two hemodynamic effects. There will be decrease in peripheral resistance. There will be increase in flow, because flow is directly proportional to perfusion pressure and inversely proportional to vascular resistance and viscosity. So immediately, because of hemodilation, so there will be a fall in peripheral resistance, which will decrease the pressure. But at the same time, because of the increase in the flow, because of the decrease in viscosity, the flow will be increased. So the fall in pressure will be matched by increase in the flow. Okay, so that's how the hemodilation works. So coming to the recommendations, what should be the hematocrit on pump? Okay, they say that it should not be below 6 or above 24. If the hematocrit on pump is above 24, you don't need to add any blood. If it is less than 6, you need to add blood. So somewhere between 18 to 24 is the target hematocrit. Most of the literature says that you maintain the hematocrit around 20 to 24 for adults and 28 to 30 for the pediatric patients. So why should we have so much low hematocrit on pump? How does it work for us? So if you look at the hematocrit and oxygen transport, so what is the relation? Okay, if you look at the relation between the oxygen transport and the hematocrit, the hematocrit values between 20 to 50. If you decrease the hematocrit from 50 to 20, from the normal 100% of the oxygen transport, there will be only 10% drop of the oxygen transport. That's how so wonderful it is. So whatever amount of hematocrit, look at the range from the 50 to 20, you bring down the hematocrit, but there will be only 10% difference of the oxygen transport, only 10% fall. So that's how they say that you can accept up to the 18%. So if you see here, below 80%, 18%, there will be steep fall in the oxygen transport. So which is not acceptable for any patient on bypass. So that's how they fix the hematocrit around 18 to 24. Coming to the hypothermia. So depending on the temperature, what temperature you use, there are different types like mild hypothermia, moderate, deep, profound. So most of the cases are done with the mild to moderate hypothermia. And again, likewise, hemodilation, the immediate effects of hypothermia are low metabolic rate and low oxygen demand. So because the metabolic rate comes down, the oxygen demand decreases, so there will be better preservation of the organs. That is the whole idea of hypothermia. But on the other side, so because of the low metabolic rate, so you have organ protection, less trauma, and provides a margin of safety. That means if something happens on bypass, there is some problem. So suddenly, if the patient temperature is low, you will have some time, because at that lower temperature, the oxygen demand will be very less, and oxygen consumption also will be low. But because of hypothermia, there can be a problem of coagulopathy or post-operative bleedings. So coming to the hemodynamic effects, because of hypothermia, there will be vasoconstriction, increase in viscosity, and left side shift of the ODC curve. So that results to increase in SVR, decrease in flow, and decrease in oxygen delivery. So if you observe closely, the hypothermia and hemodilution, they both will be acting opposite to each other. So they will be counterbalancing each other's effects, and at the end of the thing, they try to maintain the perfusion and the pressure. Okay. So coming to the acid-based management, so we have basically alpha stat versus the pH stat management. To understand this, we need to understand little basics. So according to Henry's law, the concentration of solute gas that is dissolved in a solution is directly proportional to the partial pressure of the gas above the solution. So if you apply this during hypothermia, what happens to the carbon dioxide? There will be increased solubility. So there will be decrease in the PaCO2. During hyperthermia, the solubility decreases and the PaCO2 increases. So apart from the decrease in PaCO2 levels, during hypothermia. There will be also dissociation of the most of the acids, decrease in dissociation, which may lead to alkaline pH. So there will be two things. There will be decrease in PCO2 and alkaline shift of the pH during hypothermia. So what does it mean? At 37 degrees, if you take a blood sample of a patient, the pH will be 7.445 and PCO2 around 40. At the same blood sample, if you correct the temperature to 27 degrees centigrade, the pH will be alkaline, 7.55, and PCO2 will be 20 because of the increase in the solubility. So the solubility causes increase in the CO2 level, decrease in the PCO2 levels. So what is the effect? You know that carbon CO2 is a very good cerebral vasodilator. So hypercapnia causes cerebral vasodilation and cerebral edema. On the other side, hypocapnia causes cerebral vasoconstriction and cerebral ischemia. So if you look at their effect on the oxygen dissociation curve, and there is a hyperthermia, there will be increase in PCO2 levels and decrease in the pH and rightward shift of the curve, favoring the oxygen unloading. But when there is a hypothermia, it is opposite, exactly opposite happens. There is a less favorable unloading of oxygen to the. So if you look at the alpha stat and pH stat with that background, so what is alpha stat? It is nothing but the ABG is not temperature corrected. So that means whatever ABG you take, that same temperature, you assess that, analyze that ABG with the patient temperature. You don't correct the patient temperature. So here, usually what you see, like usually you see a respiratory alkalosis for that particular temperature of patient's actual temperature. What are the advantages of having this kind of strategy? It preserves the cerebral auto-regulation and it prevents cerebral edema because there won't be cerebral vasodilation. So the blood flow will be minimal. And because there won't be any vasodilation, because there will be hypocapnia, so there will be decreased risk of cerebral embolism. On the other side, pH stat is, so when you take that sample, so you correct the temperature to 37 degrees centigrade, and to correct that, because we know that the CO2 will be more dissolvable at the low temperature. So to correct that, some amount of PCO2 will be, CO2 will be added to the sample. So that is called the pH stat of the acid-base management. So what are the advantages of this kind of strategy? It provides increased oxygen delivery to the brain because you add more oxygen, more CO2, there will be more vasodilation. So more amount of the blood flow to the brain. And it causes uniform brain cooling. And as we have seen, there will be right shift of the ODC because of the increase in the CO2. But it is very cumbersome to do this kind of strategy. So current recommendations say for all adult cases, which is mild to moderate hypothermia, alpha stat should be followed. So coming to the weaning checklist. So now the patient is on bypass. So on bypass, we have seen what are the physiological derangements, and we have understood what should be the pressure to be kept, what the flow to be kept, what should be the temperatures, and what are their effects. And now we are finally weaning the patient. So what is the checklist? So we have 9 parameters, 9 or 10 parameters. The most important one, hearing, rewarming of the patient, 32 to 37 degrees centigrade. And you make sure that depth of the anesthesia is proper before you wean the patient, because otherwise the later planes, suddenly when you wean the patient, there will be a lot of tachycardia, hypertension, and all those things. The rate and rhythm should be proper. Patient should have a normal sinus rhythm. Rate should be adequate. If it is not there, you can use pacing and connect to the pulse generator and just regulate the rate. And pump flow and BP should be proper. And metabolic parameters. So mostly you should correct the pH and you should correct the calcium levels and correct the potassium levels. And most importantly, because there will be chance of hyperkalemia because you are using high amount of potassium cardioplasia solution. So if there is any hyperkalemia, you need to correct it. And because you have put all the monitors in the silent mode, you restart your monitors and you need to de all the lines and you need to zero your online on the all the transducers and restart the ventilation, start the fluids, and if required, depending on the patient's hemodynamic profile, you can add some vasoactive agents like vasopressors or inotropes, whatever is required. That is the checklist. So most important thing is de-airing. How do you de-air? So what is this de-airing? So between the left heart, venous cannula and the aortic cannula, there is a vacuum space. So complete airtight space, and the patient is on bypass. So any breach in this space will cause air entry into the patient's systemic circulation. So how will, because the surgeon has opened the heart, sometimes right side, sometimes left side, so there will be air everywhere. So how will you de-air this before you wean this patient? So first step, occlude the venous cannula, because these things will be done by surgeon. They will occlude the venous cannula. So what happens when you occlude the venous cannula? Less amount of the blood goes to the venous reservoir, more amount comes back to the right heart. Okay, so right heart starts beating, then pulmonary artery gets filled, the blood goes to the lungs. Okay, so it is very common. The surgeon will ask you to inflate the lungs. Why? Because whatever the amount of air in the lungs will come back to the left heart through the pulmonary veins, and from pulmonary veins comes to the left heart. So when you inflate the lungs, that air comes back to the left heart, and whatever in the left atrium or whatever amount of the left ventricle. So when the heart starts beating, that amount of air will goes out through the vent cannula. So whatever cannula, Cardioplasia Cannula that surgeon used earlier, now they use it as a vent cannula. Through that cannula, they will completely de-air the heart. So this is the process of de-airing. Okay. So de-airing is done. So rewarm, so we need to ensure that patient is properly reformed, and there is an adequate depth of anesthesia. So supplement some anesthetic drugs, good rate, normal sinus rhythm, pump flow is adequate. There is pH is normal, no electrolyte abnormalities. All the monitors are proper. So you restarted the ventilation. So before restarting, you need to do some suction of the lungs and inflate the lungs. There will be some amount of atelectasis, because the lungs we are using very minimal tidal volume. So you need to inflate the lungs fully and put back the normal tidal volumes and correct other things. And depending on the requirement, if there is a vasodilation, you can use some amount of vasopressor. If the heart is bad, if the ventricle is bad, or the function is bad, you can add some inotrope. So all these things will be done by looking at the various parameters, like what is the CVP, what is the mean arterial pressure, how the heart is beating, what is the rhythm, what is the underlying disease, what is the norm, what is the LV function previously, is there any function? So many things you look before you choose your vasoactive agents. So once you do all these things, you have accepted levels of hemodynamics, you wean the patient from the bypass. Okay, so there is a video, a small video I've taken, just weaning from the bypass. So these are the hemodynamic variables you can see, just weaning. So slowly is decreasing, the pump flow has come down to 1.89 liters from the 2.22. So you do it very gradually. So when you stop all the vent and cardiac suctions and slowly fill the heart, slowly clamp the venous line slowly, so that the heart gets filled, the venous return decreases, and at the same time decrease the pump flow. Okay, so you decrease the, ask the perfusionist to decrease the pump flow, and at the same time clamp the venous line so that heart gets filled and the pumping restarts. Okay, so depending on the patient condition, like the hemodynamic profile, you need to choose your agents, like vasoactive agents, whatever is required. Okay, so coming to the complications. So most of the complications are either due to it's a combination effect of CPB circuit, which is an extracorporeal circuit, which is totally new, foreign circuit used, and other effects of hemodilation, hypothermia, anticoagulation, all will lead to so many effects like cardiac effects, cerebral, renal, GIT, pulmonary, and vasoplasia. So cardiac, they can have cardiac dysfunction, and cerebral, they can have microemboli or a stroke, post-operative stroke. The patient is, you can have, if the patient, the perfusion pressure is low, or patient has pre-operative renal dysfunction, it can be aggravated. The patient can have a pre-operative renal GAT can have a ischemia if the perfusion is not good, or pulmonary can have a pump because of the hypopermia. There can be edema of the lungs, which may aggravate the inflammatory mediators. Most of the effects are due to the inflammatory mediators, which are induced by this pump circuit, and they can give problem post-operatively. And finally, because of the enormous inflammatory mediators, there can be vasoplasic syndrome related to the pump. That is a total vasodilatation, which is requiring high dose of the vasopressors. These are the possible complications. I mean, just briefly I'm telling. So related to the cardiopulmonary bypass. So, first of the slides. So why this lecture? Okay. So now I think if you don't have a proper knowledge of conduct CPB and the physiology of CPB, so what happens? This is what exactly happens. So you should have proper knowledge. Like to have a safe flight, you should have the pilot and the flight engineers. Everybody should have a proper knowledge to avoid any crash. Likewise, you also should have a proper knowledge to have a safe and smooth conduct of the cardiopulmonary bypass. I think that finishes the cardiopulmonary bypass. I thank you again, the Sripada sir and the team for having me here. So any query?
Thank you very much, Dr. Harish, for this eloquent discourse on cardiopulmonary bypass. I request Dr. Priya to mute her mic so that we can have. Anybody have any queries? You may raise the queries directly by unmuting yourself, or post it on the chat group.
Somebody is asking something I'm not able to hear. You can put it in the chat box.
Prachis? ನೀವಾ ನಾಳೆ ಆಪರೇಷನ್ ಉಂಟಲ್ಲ ನಾವು ಅನೆಸ್ಥೇಷಿಯಾ
Dr. Priya, would you please mute your speaker?
Thank you.
Yeah, if there are no queries, I once again thank Shema Academy for having me this, and thanks Sripada sir for having me. So
Thank you, sir.
thank you.
Shripad?
Yes.
We'll move on to our.
Yeah, we may proceed to the next topic, Dr. Suma.
We will move on to our next topic. Can I have Dr. Sisla and Dr. Neha, and our moderator, Dr. Sanjay and Dr. Sharan. Dr. Priya and Dr. Sisla are from KMC Mangalore, and our moderators, Dr. Murali Shankabat, has already introduced. Over to you, Dr. Sanjay and Dr. Sharan Godapar.
Yeah, they can start presentation.
Good evening, sir. Good evening, sir. So we are final year students from Kasturba Medical College. I am Dr. Neha.
And I'm Dr. Sisla.
And we'll start our case discussion on an patient with ischemic heart disease coming for CABG. Am I audible and are the slides visible, sir?
Yeah, you can.
Your slide is visible and you're audible also.
So starting with the presentation.
Yeah, please start.
We present to you a 56-year-old gentleman residing in Mangalore. He came with complaints of chest pain, which started since 6 months. Coming to history of presenting illness, he had developed this chest pain 6 months ago, which was initially over the chest area, which was sudden in an onset and gradually increased in intensity over the past 1 month. He described it as burning type of pain, which increased while walking on level ground and was relieved by rest. There's no history of breathlessness on exertion or while lying down. He gives no history of fever, vomiting, or cough with expectoration. No history of swelling of the feet or the face or any abdominal distension. Coming to past history, he gives no history of any other comorbidities. Patient has not undergone any surgeries in the past, and there's no history of any ICU admissions. Coming to family history, there's no history of any diabetes mellitus or sudden cardiac arrest or bronchial asthma in the family. Personal history, he has a normal appetite, consuming a mixed diet, predominantly non-vegetarian type. His bowel and bladder habits are regular. The sleep is undisturbed. There's no history of any smoking or alcohol intake. Summarizing the history, this is a 56-year-old male who came with complaints of retrosternal pain, which was aggravated on doing his day-to-day activities like walking on level ground, which was relieved on rest.
Okay, only. Okay.
Yes, sir.
Can I ask some questions now?
Yes, sir.
Yeah, only complaint is chest pain. Any other complaint?
No, sir.
No, sir.
Only chest pain.
Only chest pain.
Chest pain. How do you describe chest pain in ischemic heart disease?
So usually it will be a constricting type of chest pain, sir. And it will usually be radiating to the left shoulder, the chin, the back, or even the left hand, sir.
Okay.
It can be also associated with sweating, nausea also.
Okay. So is it angina pectoris or unstable angina or what it is? How do you say, what is the definition of angina pectoris? Angina, stable angina?
Sir, unstable.
Tell about angina pectoris for stable.
Angina pectoris is usually associated with
chest pain.
Yes, sir. Usually associated with constricting type of chest pain, sir, which is relieved at rest or medication, and it's usually retrosternal in nature, sir.
Okay. Anything else? It is relieved by the rest. Right?
Rest, sir. It is relieved by rest, sir.
What about unstable angina?
So unstable angina is usually not refractory, is refractory to medications and usually not relieved by rest alone. And it is usually
it is relieved by the rest, but it takes longer time, more than maybe less than 20 minutes.
Okay, sir.
Okay, angina is a stable angina is 2 to 10 minutes. It is relieved by the rest.
Yes, sir.
This is unstable is little more severe. What are the three main causes which cause chest pain in these patients?
So spasm, sir, vasocoronary vasospasm.
No,
sir.
symptoms wise causes.
Symptoms wise, sir.
Exercise, emotion, like that.
Yes, sir. Okay. Anxiety and yes, sir.
Yes, even having food, eating food also causes angina.
Taking a bath, walking on level.
Okay, what is the difference between MI and angina? Any difference in it?
Sir, in both the patient can come with chest pain, sir, but
Yes,
on clinical evaluation and myocardial infarction, it will be associated with ST elevation and ECG and as well as elevated biomarkers, which may or may not be there in angina.
It might be there, but is it relieved by what any other disease?
And myocardial infarction won't be relieved by rest.
Relieved by rest.
It has to, some intervention has to be done.
Any other complaints will have during the ischemic heart disease patients presence other than chest pain?
So physical limitation of activities, sir.
And they might complain of
Paroxysmal nocturnal dyspnea or orthopnea.
So dyspnea also can be there.
Yes, sir.
Where do you find PND and orthopnea?
So usually in non-compensated and decompensated heart failure, patient will present with the paroxysmal nocturnal dyspnea or orthopnea, sir.
Okay, sir. Sanjay sir, you want to ask anything on the history?
Yeah, you asked about stable angina and myocardial infarction and unstable angina. Okay, I think they can go ahead further with the physical examination.
Okay, can go ahead.
Hello.
Yes. Moving to general physical examination, the patient is well built, moderately nourished with a BMI of 21 kilograms per meter square. His weight was 63.3 kgs and a height of 172 centimeters. Patient is conscious, oriented to time, place, and person. There's no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. His vitals showed a pulse rate of 80 beats per minute, which was regular in rhythm, good character and volume. All the peripheral pulses were well felt. The blood pressure was 140/70 millimeters of mercury, which was measured in the right arm sitting position. He had a respiratory rate of 16 cycles per minute, abdominal thoracic type. Saturation was 98% on room air. The GVP was not elevated. Venous axis was good, and the spine was in the midline with the spaces well balanced. Coming to airway examination, there was no loose tooth or dentures. However, there were missing teeth present. The mouth opening was more than 2 finger breadths. The temporomandibular joint indents 1 finger breadth. The tyromental distance was more than 6 centimeters. He had a normal range of neck movements, and his Mallampati was class 2. Coming to systemic examination, starting with the first system, cardiovascular system. On inspection, the shape of the precordium appears normal. There was no visible pulsation, scars, or dilated veins. The apical impulse was seen 1 centimeter medial to the mid-clavicular line. On palpation, the inspector findings were confirmed. The apex feet was felt in the left fifth intercostal space, 1 centimeter medial to the mid-clavicular line. There was no parasternal heave. On auscultation, the first and the second heart sounds were heard. There were no murmurs heard. Coming to respiratory system, there was no visible scars over the chest. Shape and symmetry of the chest were normal. The trachea appeared central in position. Bilaterally, normal vesicular breath sounds were auscultated. There was no rhonchi or crepitation. On per abdominal examination, there were no visible scars, no dilated veins. Abdomen was scaphoid in shape, no tenderness, and bowel sounds were heard. Central nervous system, the patient was conscious, oriented to time, place, and person. Higher mental functions were normal. There was no neurological deficits elicited. Summarizing along with the examination findings, this is a 56-year-old male who has come with complaints of angina, probably stable type, not in failure, posted for coronary artery bypass grafting.
You did not have any any physical findings in this patient?
No, no, sir.
So in that case, how would you proceed? What investigations you would order to help you in your diagnosis?
So I would like to first take a pre-operative ECG, sir.
Okay.
Sir, since the patient is posted for CABG, sir, I would like to go ahead and ask for complete blood counts, including hemoglobin, platelets, and also total count. I would also like to ask for a renal function test, including blood urea and serum creatinine, sir. I would also like to ask for serum electrolytes and liver function tests. I would also like any pre-operative angiogram which has been done over the past 12 months would suffice, sir. Other than that, I would also like to ask for blood grouping and typing, and of course a COVID testing, sir. A pre-operative echo is also usually recommended since it's a vascular procedure, and an X-ray, sir.
Okay. So why the ECG is important? What will you gain from the ECG?
Sir, first of all, we'll be able to identify what nature of, based on the nature of angina, sir. Usually more changes will be present in unstable angina as compared to stable angina. Also, if the patient had a previous history of MI, sir.
Hello.
If the patient has had, sir? Yes, sir. Previous history of MI, he may present with Q waves in the respective regions, sir. Other than that, sir, also we might be able to identify if the patient was on medications previously, we'd be able to identify electrolyte abnormalities also through the ECG, sir. ST segment elevation, sir. And
yeah, ST segment elevation. Can you describe about this? Why ST segment elevation is important? What are the two types of ECG that you will describe in a patient who has come with a chest pain?
ST segment, sir, STEMI and non-STEMI, sir. In ST segment elevation MI and non-ST segment elevation MI, sir.
Okay. What does it indicate? ST segment elevation MI and non-ST segment elevation MI.
ST segment elevation MI will be associated with myocardial infarction, sir, and including requiring immediate immediate assistance, a medical assistance such as percutaneous intervention, sir.
Okay.
Whereas non-STEMI can be usually managed medically, sir, by treating with thrombolytics or antiplatelet agents, sir.
Yeah, I mean, ST segment elevation is important in the way that there is a definite treatment that needs to be undertaken, and yes, it invariably percutaneous intervention, and it is time bound, and within a particular hours, within 12 hours, you need to establish the blood flow, and that's the importance of STEMI. So you need to identify it early and then treat it immediately.
Yes, sir. Yes.
That ST segment elevation occurs when there is a transmural infarct.
Yes, sir.
Because with the non-ST elevated MI, you have no option of doing a PCI immediately, and it does not help. And hence, you have to look for other medical options.
Yes.
Right?
Yes.
So that's the difference between STEMI and non-STEMI.
Yes.
Okay. How do you assess the functional capacity of this patient?
Sure, sir, during history, we'll be able to elicit the metabolic equivalence, sir.
Okay.
So we'll be able to, if the patient usually has a METs of more than 4, sir, metabolic equivalence of more than 4, then generally it means that he's able to climb at least 1 flight of stairs and able to do his day-to-day activities, sir. So such patients are less at risk, sir. And other than that, sir, also based on the on how the symptoms limit their activities, sir, such as we'll be able to grade as per NYHA, sir.
Okay. Can you describe the NYHA classification?
Yes, sir. Hello, sir. Am I audible?
Yes,
yes. Sir, NYHA classification, sir, there's class 1 where there is no limitation of physical activity, even on strenuous exercise, sir. And say grade grade 2 is patients with cardiac disease with slight limitation of physical activity, but they're comfortable at rest, sir. But ordinary physical activity will result in fatigue, angina, or dyspnea, sir. Then there is marked limitation of physical activity, but they're again comfortable at rest. Less than ordinary physical activity can cause angina, fatigue, or dyspnea, or patients with cardiac disease unable to carry out any physical activity without discomfort, and patient will even be symptomatic at rest. This is as per NYHA, so grade 1, 2, 3, and 4.
Okay. Sharon, you want to ask?
Yeah, in the ECG wise, how do you find out which valve is involved or whatever this thing? Like which leaders and all you are going to look at that?
The anterolateral leads will generally include all the leads from V4 to V6, sir. And if the septum is involved, V4, sir. 2, 3 AVF is inferior wall MI, sir. And yes, sir, that's all.
Okay.
Sir, right-sided precordial leads can show posterior wall MI, sir.
Okay. So what is the changes happens like injury? What in ECG, injury, ischemia, and infarction? What are the changes? Where what level it happens?
Sir, as in previous history of MI will be represented by Q waves
Yes.
in
Loss
the
of
respective
QRS.
leads. Yes, sir. And there will also be poor R wave progression if the patient has some diastolic dysfunction, sir. Then if the patient has left ventricular hypertrophy because of long-standing hypertension, then there will be associated LVH changes, lead associated changes. And ST segment elevation if he is having myocardial infarction, sir.
No. Myocardial infarction always Q waves. ST segment elevation is a injury usually.
Yes, sir. Yes, sir.
And ischemia is presented by T wave inversions. Okay.
Okay. Okay.
Okay. Next, echocardiography is done for this patient.
Yes, sir.
Why echocardiography is important in this patient?
Sir, we'll be able to assess all the cardiac chambers, sir. That is the function and also their sizes, sir. We'll be able to identify if there is any left ventricular regional wall motion abnormalities, any diastolic dysfunctions. We'll be able to grade the diastolic dysfunction, any raise in pulmonary artery systolic pressures, any valvular abnormalities, including aortic regurgitation or age-associated aortic sclerosis. We may also be able
ejection fraction and appropriately look out for the perioperative risk associated.
Yes, sir.
If it's less than 50%, the periop morbidity is high.
Okay. Other than this, any other investigations you want to do?
Sir, then based on the requirement of the patient, sir, we can ask for a pre-operative pulmonary function test if he's a known case of COPD, or we can even ask for an endoscopic GI examination if he has a chronic liver disease.
No. Cardiac-wise.
So, stress testing, sir. Is if the patient presents with stable angina?
Yeah, that is already TMT is already done. That is also one of the things.
Yes, sir. Stable angina patients we can ask.
Viability of the heart and all any other investigations they do usually sometimes.
Technetium 99.
Yeah.
Technetium 99 and test, sir.
Yeah, they'll do that. Radionuclides scanning also can be done.
Okay.
Okay,
Yes.
sir. Anything else you want to ask, sir? Investigations?
So we can ask for cardiac enzymes. That is troponin, CKMB. Yes, sir. And other than that, sir, HbA1c if the patient is diabetic, sir.
Okay. And in blood investigations, you wanted to ask for LFT. Why you want LFT?
Sir, for to know what drugs are safe to use in these patients, sir.
Anything else?
Sir, in case of right ventricular failure, it may be associated with elevated liver enzymes.
Okay, fine. Liver enzymes are normal only in most of the patients. Why we ask? Why it is important? We need to have a baseline. All the end organs. What are the end organs? Like for example, liver, kidney are all important to us because we will be putting this patient on bypass.
Yes, sir.
There can be some hypoperfusion or bypass itself can cause some pathology. So the enzymes can be raised or there might be dysfunction of this liver, kidney organs post bypass. So we need to know beforehand only whether the organs are normal or not. Okay, the function is normal. Okay.
One more thing regarding this assessment of a patient in the preoperative period, you were discussing about the ECG and echo and nuclear scan. Can you just discuss about exercise ECG, stress test, and stress echo and also nuclear scan? Why is it important? And what information you get from them?
I don't know, sir.
Okay. Now, it's important because it gives you what is the functional capacity of the patient. A patient might not have any symptoms or might not have any changes, investigations, routine investigation that you do. So if you want to stress the patient, obviously the best would be to go through a treadmill test. And treadmill ECG is not a very sensitive investigation. And many times you see that the patients are not able to exercise. They have some physical limitations, or are not in a position to do it, or they have some ECG changes in that which cannot be interpreted as ischemia. So in those situations, you have certain other options like debutamen stress echo or exercise echo, or even these nuclear scans, which will give you an indication whether the patient has got ischemia and how significant is this ischemia. So this is important when the patient comes for not only cardiac surgery, even for non-cardiac surgery. And cardiologist may advise a patient to undergo these tests when you cannot estimate the ischemic component by other means or routine means.
Okay. Okay.
Right. You can proceed now. Can you just describe about the coronary anatomy?
Yes, sir. So the coronary arteries basically arise from the root of the aorta. There's a right coronary artery and the left coronary artery. The right coronary artery continues as the left has two minor as well as major branches. The minor branches include the SA node artery as well as the AV node artery, and whereas it will continue as the right. The acute marginal, it will continue as the posterior left ventricular artery and posterior descending artery, sir, which runs through the intraventricular septum, sir, in the posterior aspect, whereas the left main coronary artery divides into the left circumflex and the left anterior descending. The left anterior descending has septal as well as septal perforators and diagonal branches, whereas the left circumflex will also have obtuse marginal branches, sir.
What is left dominant heart? I mean, I don't know whether it's
so that's based on
dominant
how
and left right dominant.
Yes, sir, based on where the posterior descending artery arises from.
Yeah.
So if it arises from right coronary artery, it's right dominant. If it arises from the left coronary artery, it will be left dominant. Sir.
Okay. Why EF is important? Why end diastolic volume is LV size is important in echo? Then since you are talking about coronary anatomy, coronary.
So it's usually during the since major portion of the heart is supplied by the left coronary artery, and the left coronary flow happens during the diastole, sir. So any diastolic dysfunction will be associated with the reduced perfusion, sir.
Okay, what is coronary blood flow? How do you measure?
Sir?
Coronary blood flow.
Coronary blood flow, how to measure, sir?
Yes. What measure means, like, for example, it depends upon the diastolic pressure minus
LVEDD minus
LVED. Yes. If LVDP goes up, if the LVDP goes up, the chamber is enlarged, then the blood flow will be less. Right?
Yes. Yes, sir.
So diastolic minus LVD.
Yes.
Okay, sir. We have to go for the case also, no, sir? No. I mean, like posted for cases.
Yeah. Before going to the case proper, just describe a brief what are the factors involved in myocardial oxygen supply and demand.
So the oxygen supply depends on mainly the oxygen content of the blood, that's saturation, and also the coronary blood flow. Coronary blood flow is in turn dependent on the diastolic blood pressure, the left ventricular end diastolic pressure, the patency of the coronaries, and the tone of the coronaries. The oxygen demand depends on the contractile state of the heart. That is shown by either the afterload or preload. The heart rate. Hello, sir. Am I audible now?
Yes, yes.
So the oxygen supply, so it depends on the oxygen concentration in the blood. That is that depends on the hemoglobin of the patient and the saturation per se. And it also depends on the coronary blood flow. That depends on the diastolic blood pressure and the left ventricular end diastolic pressure and the patency and the tone of the coronaries. The oxygen demand depends on the contractile state of the heart, the afterload and preload, and the heart rate and the wall tension.
So what is common in both?
Heart rate, sir.
Heart rate. So it's very important that you prevent the heart rate from rising because both of them will jeopardize the oxygen supply as well as they increase the oxygen demand. So it's one important thing that you need to keep it in mind.
Yes.
Okay. Okay, you can go ahead with the case presentation now. Or what for the CABG, isn't it?
Yes, sir.
All right.
What pre-medication you want? How do you prepare the patient?
Yeah, go ahead.
So I would pre-operatively, sir, if the patient comes at least 6 hours after his episode, sir, then I'd like to optimize the patient's pre-operative diabetes mellitus status, his hypertension, and good so we should establish good patient communication, sir, to avoid anxiety-induced tachycardia. I would like to take a written informed consent regarding the risk associated with the surgery, since this is categorized as a vascular high-risk procedure. I would like to explain about all the mortality, perioperative mortality, and the morbidity associated with the procedure. I would also like to inform him about the NPO orders. That is, he should be nil per oral for solids for 8 hours and for clear liquids for 2 hours, sir.
Pre-medication.
Sir, pre-medication, sir, I would like to, if the patient is on...
I'd like to give tablet alprazolam 0.25 HS in coming morning, and tablet pan as well, 40 mg OD, and also to reserve adequate blood and blood products.
What about antihypertensives? What you are going to do?
If the patient is already on beta blockers, I would like to ask the patient to continue the same even on the day of surgery. AC inhibitors to be stopped on the day of surgery.
Calcium channel blockers?
Calcium channel can be continued, sir. Nitrates, calcium channel blockers, and beta blockers can be continued, sir.
Okay. Any other pre-medication you want to do? On the morning of the surgery?
So tablet pan and alprazolam, sir, anti-anxiolytics.
Okay, some lorazepam or middle you can give.
Yes, sir.
And some centers they give even IM morphine also. So nowadays people are not practicing that much.
Yes.
Oh, okay.
Okay. So what? Okay. Sir, anything else you want to say?
So if the patient is on oral hypoglycemics, it has to be withheld on the day of surgery.
Yeah, that's fine. We can go ahead with the management now.
So on the day of the surgery, I would like to keep the OT ready, check the machine, check for all the emergency medications, including atropine, adrenaline, phenylephrine, and calcium gluconate should be loaded and kept ready. Airway equipments.
No. 1 minute.
Yes.
Another thing we didn't discuss is patient will be on aspirin and antiplatelets and other drugs.
Yes, sir.
Sometimes even on oral anticoagulants also. What is your advice before taking the case?
Sir, usually if the patient comes on clopidogrel to the hospital, we'll wait for 4 to 5 days. Start the patient on IV heparin, bridging therapy, sir.
With heparin.
And if the patient is on aspirin, it can be taken even on the day of the surgery, sir.
Okay. Sometimes they will stop at least 2 days before also. That is also it. Okay. If warfarin or patient is on warfarin, sometimes they will be on warfarin also.
Yes, sir. Warfarin has to be stopped and has to be bridged with IV heparin, and it should be monitored preoperatively with PTINR values, sir.
Okay. It has to have at least 4 or 5 days before the surgery and monitor PTINR.
Yes.
Okay, this also you should tell in pre-medication whether you are stopping these drugs or not. Okay.
Okay.
Pre-medication, pre-op assessment.
Okay. Okay. On the day. Sir, I'll continue, sir.
Describe the monitors that which are relevant in this case.
Sir,
Pre-induction, I'd like to connect the patient to a 5-lead ECG, pulse oximeter, and also have invasive blood pressure monitoring. Then
blood pressure monitoring, central line has to be inserted via the right IJV, sir, for monitoring the right atrial pressure, for monitoring the CVP, sir, and also temperature monitoring and urine output monitoring, sir. So the urine output monitoring, we can insert also a bladder temperature probe, sir, and nasopharyngeal probe, sir. If it is relevant, we can even use a transesophageal echocardiography, sir.
What is the role of pulmonary artery catheter?
Sir, role of pulmonary, so it helps in calculating the cardiac outputs, intraoperative cardiac output, pulmonary capillary wedge pressures, and also it gives us a pulmonary artery pressure, sir.
When do you use it?
Sir, recently, sir, so in patients with pre-operatively, if his echo shows pulmonary artery hypertension, sir, the patient has a very low. If patient has any diastolic dysfunction, sir, ejection fraction is less than 45%, sir.
Yeah, routinely it is not used, but
yes, sir, routinely it's
not a high risk, especially with the low ejection fraction, poor LV contractility, and a pulmonary artery pressure is high. You can use it to detect ischemia as well as to calculate the cardiac output. Also, it might be useful. But nowadays, of course, we have transesophageal echocardiography, which is much less invasive when compared to pulmonary artery catheter. You should know the complications of pulmonary artery catheterization. Can you just describe the complications?
Sir, complications, sir, during insertion, sir, there might be technical difficulties, and also there might be difficulties associated while passing the catheter, sir. Technical difficulties, it may even rupture the pulmonary artery, sir, and there can be air embolism, sir. Other than that, sir, it can impinge against any of the walls and also cause arrhythmias.
Yes.
Then rupture when it's a rupture of the right. I mean, if usually it is contraindicated in patient. Sir, right bundle branch block, sir. Then it may be associated with reduced blood flow from different from the part of the lungs, sir. It can. Yes, sir. Then there might be technical difficulties include while passing of catheter. There might be knotting of catheter, coiling of catheter, sir.
Yeah, good. So it has got some major complications associated with it, especially the pulmonary hemorrhage is very dreaded complication of this. Yeah.
Yes.
Okay, that's good. Okay. Sharnu, you want to proceed?
Yeah, we'll go to OT procedures.
Sir, yes, sir. Sir, I'd also like to. Sir?
Okay, tell me what you are.
Sir, I'd also like to make sure that we have arterial blood gas analysis and ACT, sir, automatic clotting time, sir, and the bypass has to be checked and kept ready, sir, and be on standby, sir. Then, pre-operatively, even before draping, defibrillator pads has to be attached, sir. Yes, sir.
No, pads are not attached. Defibrillator has to be kept ready. That's it.
Yes, yes. So, yes,
Okay.
sir.
Next, how do you induce this patient?
Once I've obtained all the invasive invasive monitors, I'd like to, patient is usually in supine position, and I would like to pre-oxygenate for 3 to 5 minutes. And I would like to, during this, and I would like to pre-medicate the patient with fentanyl 3 to 5 micrograms per kg, sir. And I would like to use propofol, sir, 2 mg per kg, sir. And I would like to use vecuronium as my neuromuscular blocker, sir. 0.1 mg per kg, sir.
Okay.
And then I would like to secure his airway with a normal oral cuffed endotracheal tube, sir, PVC type. And I would like to connect it to the ventilator after confirming bilateral entry and capnography, sir. I'd like to maintain I would like to maintain the depth of anesthesia with nitrous and oxygen and isoflurane, usually maintaining a MAC of 1 to 1.2, sir. And
Any other induction agent you want to use?
Sir?
Any other induction agent?
So if the patient has
IV
low
induction.
reserves, then I would like to use etomidate, sir.
Okay, what is the dose?
Sir?
Have you ever used?
Sir?
You have used the drug, you have seen?
Yes, sir. In case etomidate is here we've used for left main disease, sir. Left main coronary disease.
Left main disease. Okay. To be precise, it should be used in low EF patients.
Yes, sir. Low EF patient.
So midazolam don't use? You have never told that in the induction.
Sir, while we were attaching the monitors and securing the invasive lines, patient can be given pre-medicated with midazolam 0.1 mg per kg and
not pre-medication, during induction only we are using. Okay.
Yes. Oh, okay, sir.
Okay. You said DF of this patient is how much?
45.
So it is
45%.
So after intubation, there will be hypertension and blood off topic, then tachycardia. Then what you are going to do?
Sir, since we have a central venous catheter and since we kept the OT ready for inotropes, we can connect the inotropes, sir. I'd like to use adrenaline, noradrenaline, and adrenaline, sir.
You want to use some volume or something like that?
Yes, sir.
More volume?
Yes, sir. Yes, sir. Volume resuscitation.
Why volume is required after induction sometimes?
Patient is on NPO, sir.
Okay. Anything else?
Patients on
AC inhibitors, diuretics.
There will be some vasodilation, right?
Yes, sir. Yes, sir.
So you have to use volume plus inotropes.
Yes, sir. Yes.
Okay. You have ST elevation as soon as you induce the patient. What is your strategy?
Sir, I would like to start the patient on nitroglycerin, sir, 0.5 microgram. We can titrate it up to 3 microgram per kg per minute, sir.
Okay.
And I can also use IV levetolol, IV metoprolol or esmolol also, sir.
Levetolol?
To maintain the rate, sir. To maintain the rate.
Levetolol is not used. Usually, esmolol you can tell. Okay.
Yes. Okay, sir.
Okay.
How will you detect ischemia?
Sir?
How will you detect intraoperatively? How will you detect the ischemia?
So the ECG, 5-lead ECG, most of the monitors now also have ST analysis, sir. So while constantly monitoring the ST analysis, you can make out if there's any ischemia. Also, there will be associated tachycardia and hypertension, refractory to vasopressin.
ST changes will not be there. You don't want to see
Sir?
ST changes, ma.
Yes, sir.
Yeah, sir is asking. How do you?
Look, sir, lead V5, sir, V5 lead, sir. We look for ischemia and lead V5.
ST elevation.
ST elevation, sir.
It can be also ST depression.
Okay. Anything else? If you have a pulmonary artery catheter, how will you diagnose?
Yes, sir. So cardiac output and cardiac index can also be measured. This will be less. This will be reduced, sir, if we have a pulmonary artery catheter in situ, sir.
Cardiac output and cardiac index. Anything else? In the
So transesophageal echo.
Usually we don't put on 1 minute in PA catheter. We usually don't put cardiac output monitoring catheter. Okay, you just put PA catheter. What else? What do you see in PA catheter?
So pulmonary artery pressures and pulmonary capillary wedge pressures.
Tell what happens to the pulmonary artery pressure, what happens to the diastolic pulmonary pressure, systolic pressure, mean pressure. That is important.
Yes, sir.
Okay, cardiac induction and all, it will take time, right?
Yes, sir.
Okay. Yeah, go ahead. You're telling something else. After the induction, another monitor you are going to use. What is that? Nowadays, all the patients were putting.
BIS monitoring?
No.
Neuromuscular monitoring?
No. Regarding cardiac function.
You are talking about it.
You just told me.
Transesophageal echo, sir.
Okay. So, sir asked questions.
Did it tell you about ischemia?
Yeah,
so you can
detect the regional wall motion abnormalities, sir.
Okay, which is the most sensitive indicator and which is earliest?
Transesophageal echo, sir.
If you have put a transesophageal echo, you will be able to detect the regional wall motion much earlier. Okay.
Yes.
So that's how we detect ischemia. And the treatment you already mentioned about this: nitrates and beta blockers and calcium channel blockers.
And inotropes if it is required.
Yes.
So what is this patient undergoing? Is it an off-pump CABG or on pump?
Sir. Off pump, sir.
You're talking about. Can you just tell us what are the difference between off pump and on pump, and what are the advantages and disadvantages?
Sir, off pump is usually has transient coronary ischemia as compared to on pump, which has global myocardial ischemia, sir. Heparin dosages will also be lesser in off pump, sir. For side effects associated with CPB, it is more drug pharmacokinetics is more predictable off pump, sir. Intraoperative awareness is less with off pump, sir. Also, lung injury and all other end organ injuries is less in off pump, especially neuropsychiatric patients. Neuropsychiatric impairment is less than 1%, sir. Also, the cardiac markers are less released during off pump, sir. Renal function is better preserved. Platelet function is also not altered, sir. Post-operatively, arrhythmias, use of antiarrhythmics, use of inotropes, and also inotropic support is all lesser in off pumps, sir.
Okay. So,
on pump, the advantage is yes.
Yes, tell. Go ahead.
Which patient you advise to go on pump,
the
and which patient you advise surgeon to go do it off pump? Which kind of patients?
Patients with reduced ejection fraction of less than 50%, we would prefer on pumps.
Okay. Okay, this patient we are going to off pump, right?
Yes.
Okay, go ahead. So what are the graphs they are doing? What is your role during off pump?
So yes, sir. So first, so based on different stages, sir. during sternotomy, a patient may develop hypertension and tachycardia. So that has to be obtunded by giving opioids, sir. Next, we have to graft the saphenous vein, sir, or the radial artery can be dissected, sir. Then next is left internal mammary harvesting, sir. Then these are the two grafts that I would like to harvest. That will be harvested, sir. Next, prior to the internal mammary artery grafting, I would like to give the patient heparin 2 mg per kg, sir.
How much ACT you want to maintain?
Sir?
ACT more than
ACT
300.
you want to maintain?
So ACT should be maintained around 400, so more than 400.
For open surgery also?
More than 300.
More than 300.
Seconds is outside.
Yeah, more than 250 should be all right. Okay, for open surgeries. Some surgeons prefer to give 1 milligram or 2 milligram also can be given. Some advise to give even 4 milligram for open pulse, right?
Okay.
Okay.
What is your role during grafting?
Yeah,
so we have to give fluid resuscitation, sir, during grafting is required, sir. And we have to, based on, sir, also low tidal, during sternotomy, we generally switch off the ventilation, sir. And we have to stop the ventilation for a short period of time. During lima grafting, sir, we have to make sure that we provide low volume ventilation, which can either be done with by hand ventilation or by maintaining low tidal volumes with high respiratory rates, sir.
What about hemodynamics during grafting?
Sir, so during grafting, we should prevent hypotension, sir. We can give IV fluids during fall and preload, sir. We can give a 20-degree Trendelenburg positioning, which will improve the preload. Other than that, sir, we can also start, if still there is hypotension, then we can start the patient on dobutamine or dopamine infusion to maintain the BP, sir.
Any other drug sometimes they use? Any other drug?
Phenylephrine, sir.
No. Okay, that is for momentary. Another infusion they use most of the surgeons nowadays. You have seen beating heart surgeries, right?
Yes, sir.
Okay, noradrenaline do you use in your center?
Yes, sir. Yes, sir. Adrenaline, noradrenaline, dopamine, sir. Yes.
Okay, you want to maintain pressure with that, right?
Yes, sir.
You have started adrenaline, noradrenaline, still not able to. How much mean pressure you want to maintain during grafting, LED grafting?
So since this patient
what is
has
your target?
Since this patient has no comorbidities, we can maintain it more than 60, sir. 60 mm.
60, it will be less.
Okay. That.
At least 80 mean pressure has to be maintained.
Okay, sir.
Okay, if you are not able to maintain, what will do? In spite of all this twice?
We have to switch to pumps.
We can switch to pump or yes, sir.
Okay. Any beta blockers you want to use during this? Tachycardia is there?
Metoprolol can be given, so 1 to 1.5.
Straight away. No, you should use a smaller, which acts for only 5 to 10 minutes. Okay.
Yes.
During grafting, you should use a smaller.
Okay.
Metoprolol is a long acting, right?
Yes, sir.
Short acting drug you have to use.
Yes, sir.
Okay. So how many grafts they are doing this patient?
3, sir.
Okay. So LED and OM and right side, right?
Yes, sir.
In which of the grafting this position grafting more do you expect hemodynamic instability? More,
While grafting the right.
right? OM
Because they'll be lifting the heart.
They'll be lifting the heart, sir. Obtuse marginum, sir.
So it is not right one, that is left heart only, left side, circumflex.
Obtuse mark.
Posterior
descending.
descent.
Posterior descending anastomosis.
Yeah, anything on the obtuse marginal and where they have to lift the heart
Yes, sir.
will have maximum hemodynamic problems.
Yes, sir.
So what complications you can expect during this surgery?
Hybrid. Yes, sir. Orange thing, Papa Gate. Delhi on.
Hello.
Yes, sir.
Yes, sir.
So someone's mic is on, sir.
Yeah, some Jyotis.
ज़्यादा spicy मत करो.
Hello.
वो दूसरी है वो.
No, sir. So that's not.
Okay.
Hello, Jyoti Mantur, can you mute your mic? Hello.
Yes, sir.
Do you speak on this? Metro. So kapri rana full dumb. वो बंदा.
Can you go ahead?
Jyoti, could you keep your speaker switched off, please?
Hello, Dr. Jyoti. Hello.
Yes, sir.
Yes.
Okay, sir. We'll continue, sir.
Yeah, you
Yes, sir.
continue. So what are the complications you are likely to face?
I'm sorry, sir. We couldn't hear the question.
What are the complications associated with
Monday.
bypass?
Good. Not usual.
Sir asked complications.
Complications associated with, sir?
Pre-Operative, Gujarat में क्या था? What thing?
Jyoti के
Pump
संते.
CABG.
Hemodynamic instability, sir. Hypertension.
Yes.
Suma, can you mute her?
Sir, we can't hear anything, sir.
There's a lot of disturbance. Can somebody mute?
Suma, can you mute her, Dr. Jyoti?
I'll do that.
This, what does brain mean in Gujarati?
Jyoti,
Any double meaning is there?
Jyoti.
Heli follow ಮಾಡ್ತಿ ಇನ್ಸ್ಟಾ ಒಳಗ. ಒಬ್ಬಾಕಿ ಅಳಾತ. ಗುಜರಾತ್.
Hemodynamic instability, bleeding, cognitive dysfunction, LV dysfunction post-operatively.
If there is severe LV dysfunction,
Yes,
what will you do? Intraoperatively, when the surgeon is grafting, there is severe hypotension, which is not amenable to your usual maneuvers of fluid overload and tilting the table, inotrope, etc. There's a lot of ST changes that are taking place.
Then I'd like to, if it's persisting for more than 15 minutes, I'd like to go on pump, sir.
Go on pump. Okay. So on pump, how will pump help in this situation? How will it help?
Sir?
How it will help pump? Sir,
How will,
going on pump, how it will help us?
Regulate. So we,
yeah, I think she muted now.
Sorry for that interruption.
so it's more,
It's okay.
sir, it's cardioprotective, sir. CPB, using CPB is more cardioprotective, sir. And also we can provide a bloodless field for the surgeon, sir. So
the patient becomes unstable, and it's natural to go on bypass, because one is to stabilize the hemodynamics, right?
yes, sir.
On cardiopulmonary bypass, you have complete control over the systemic circulation, which you are providing at that particular moment. And then also it is cardioprotective, because you can unload the heart, okay? And the heart is not struggling at that time. So giving a period of rest to the heart itself will allow the myocardium to recover. And on bypass, you can think of other options while coming off bypass, whether the patient needs any more support, any other modalities of support.
Yes.
What other mechanical supports the surgeon might think of while coming off bypass?
Intra-aortic balloon pumps, sir. Then there is ventricular assist.
How does it help?
Sir, it helps to augment during systole, sir, the balloon will
diastole, the balloon will inflate.
Yeah, diastole, the balloon will,
yes,
sir. During diastole, the balloon will inflate to maintain the coronary perfusion, sir. And the patient's BP can be augmented at 1:1, sir.
No,
so where is the balloon position?
What happens?
Sir?
Where is the balloon position?
It's in the aorta. So it is the balloon is inserted into the aorta, sir.
Which part of aorta?
Descending aorta, sir. Thoracic
so
aorta.
It's the thoracic aorta.
Yes, sir.
Distal to the subclavian artery.
Left subclavian.
Left subclavian artery. Okay. As you said, during diastole, the balloon inflates and augmenting the diastolic flow, which will help in coronary circulation. And during systole, the balloon collapses and improves the afterload. So that's an excellent mechanical device which helps in assisting the left ventricle while coming off bypass.
Yes.
Okay.
Yes.
All right. Sharanu, you want to ask?
Yeah. What inotropes you want to use after coming off bypass?
So adrenaline, noradrenaline, and dopamine, sir. Dobutamine, sir.
Okay. Okay.
Yes.
So, what are the dose you want to use? Dobutamine? Hello?
Yes, sir. Don't know, sir. Don't know.
Okay. You should know the doses of all these drugs. It should be started with 5 microgram dopamine or dobutamine, then adrenaline 0.05 to you can go up till 0.2
microgram per kg.
Yes. Norad also same 0.05 to
0.1 microgram.
0.2 microgram you can. Okay.
Yes. Yes, sir.
But still you don't maintain the pressure, hypertension is there, then mechanical support, as we just now discussed, IABP has to be inserted. Okay. Yes. And during all this period, you need to monitor EV function by TE.
Yes, sir. Yes,
if
sir.
any segment is not functioning well or any hypokinesia is there, you need to tell surgeon to look at the graft, whether it is patent or not. Okay.
Yes.
Sometimes we need to raise the graft. There might be some clot or there might be some mechanical obstruction.
Yes.
Okay.
Okay. So, what about the post-operative management? What are the?
I'd like to shift the patient with all the monitors in situ, sir, and also like to keep ready all the emergency drugs. And we can patient should be continued on whatever inotropic support that he is on, sir. And once I'd like to continue the mechanical ventilation, sir, post-op mechanical ventilation.
How long you want to continue ventilation?
So till the patient awakens from, till the patient is responsive to oral commands, sir, till he is on minimal, if the ABG that is done is showing normal values, sir, and stable hemodynamics, sir, then I'd like to extubate the patient. But patient should be awake and obeying commands, sir.
Okay. So do you mean to say you deliberately ventilate the patient post-operatively for a certain length of time, or you want to wake up the patient immediately as soon as the patient wakes up in the post-operative period?
No, sir, I would like to do a post-operative elective ventilation, sir, after a while, because if the patient was on pump, then I'd definitely like to go for post-op ventilation, sir.
Okay. No, there was a tendency to use a fast tracking wherein you
yes, sir. Yes, sir.
extubate the patient within 2 to 3 hours, but generally that is not considered to be very safe because patient is just pre-warming, and there may be the coagulation status is still not settled, hemodynamics is just settling down. So patients usually tend to ventilate for about 4 to 6 or 8 hours post-operatively till everything gets settled. Dr. Sharon, you have anything regarding this fast tracking?
We can extubate if half pump is done, sir, 2-3 hours. But usually it takes 5 to 4 hours.
Yes, sir.
So that is the thing.
Yes.
Any role of regional anesthesia
thoracic
in CABG patient, in your patient?
So we can put in a thoracic epidural, sir, for pain management.
When do you put? Where do you put?
Sir, at T6, T7 level, sir, and I'd like to thread in the catheter up to T4,
When do you put? After induction or before induction or one day before?
1 day.
Huh?
1 day.
1 day before.
1 day before surgery, sir.
Yeah, some people put 1 day, I mean, at least 6 hours before also. Or is there any relation between putting epidural catheter and heparin injection time?
Sir, it has to be stopped at least 6 hours, because if you're using low molecular unfractionated heparin, then we can stop heparin 4 to 6 hours before placement of the epidural, sir.
Okay, usually it's better to put at least 6 hours before the surgery so that heparin can be given later. If any bleeding is there, it will stop. Okay, they use some epidural also. Okay.
Yes.
Okay.
Post-op analgesia, what do you want to use?
I'd like to use subcutaneous morphine or opioids.
Subcutaneous morphine? You are all using subcutaneous morphine?
No, sir. Fentanyl also can be used, sir.
Subcutaneous?
No, sir. IV fentanyl, sir.
Okay. Any other drug? No new drug there people are using nowadays?
Dexmed.
Yes, correct. Are you using Dexmed?
No, sir. No, sir.
It can also be used.
Yes, sir. Yes,
Infusion dose, it can also be used.
Yes.
Sanjay sir, anything else you want?
I think it's fine. Can we conclude now? I think
yes, sir. Yes.
Come to the post-operative management. It's fine. I think they've done a good job, students. It's nice.
Thank you, sir.
How many months you get posted in cardiac usually?
Presented this topic, which is usually, asked for a
DM or
fellowship examination, and you as undergraduates, you're able to talk about the management.
So in one postings, we get generally posted for a month, sir.
Okay, good. But what happens is, what I generally see is it takes some time for you to get to know what is that cardiopulmonary bypass.
Yes, sir. Yes, sir.
Yes.
So usually it's not that easy to pick up things, but you
At
should
least
know
2
the
months posting is
basic,
required
yeah.
minimum.
Okay, good.
Good.
Thank you, sir.
Thank you, sir.
Thank you for giving us this opportunity, sir.
Okay.
Thank you, sir.
Thank
Okay,
you.
what is this?
Thank you, Dr.
Thank you, sir.
Mahendra, Dr. Suma, and all of from Kshema, the faculty, was given us the opportunity to take part in this academic activity. Thank you.
Thank you,
Thank you,
Dr.
sir. Thank you,
Sanjay and,
Sripad, sir,
Dr.
Suma.
Sorry, please go on.
Yeah, nothing, sir. Thank you. Thank you very much, sir, giving this opportunity.
Thank you, Dr. Sanjay and Dr. Sharan Patil. It was an excellent discussion. Actually, I also learned a lot of things from this discussion. Thank you very much for your time and preparation.
Thank you so much, Sripad,
I
sir.
also thank Dr. Neha and Dr. Sisla, but I think you could put on your video for a minute so that we can see who is this person at the other end answering all the questions very efficiently.
No, both of them didn't put up.
I think you forgot to put on your videos. When so many people watching, it is good to see who is answering so nicely.
Yeah, presenter always should put it.
Yeah. Okay, thank you so much. You did a very good job. I again thank you, Dr. Sanjay and Dr. Sharan Patil.
Yes, sir.
Thank you, Sumama. Thank you so much. Thank you so much, sir.
Now we'll proceed to the next part of the event, that is a discussion on video laryngoscopes by Dr. Apex Patwa. He is the secretary of All India Difficult Area Association and inventor of Patwasha eye video laryngoscope. He is going to discuss on
Greetings from Borderland. It's really a pleasure to be here with all of you. Greetings from Borderland. It's really a pleasure to be here.
Is going to discuss about video laryngoscopes. Over to Dr. Apex Patwa.
With all of you.
Are you able to see?
Going to talk on basics of video laryngoscopy. So there are a lot of concerns related to direct laryngoscopy. You need to apply force. You need to align it.
Are you able to hear? Dr. Suma?
And if you look at the video laryngoscope success rate, success of intubation is much higher compared to direct laryngoscopy. Why it is so? For that, we need to understand the basics of video laryngoscopy. Means we need to understand what is video laryngoscope. So nowadays, compact, robust, high resolution video camera are available, which is to be embedded a few centimeters proximal to tip of any laryngoscope, which convert laryngoscope into video laryngoscope. Same sense, if we apply or if we attach the industrial camera to McIntosh blade, it converts this as a McIntosh type video laryngoscope. But whether this serve the purpose or not, for that we need to understand how video laryngoscope works. As with the direct laryngoscope, video laryngoscopic intervention is also having three components. First, we need to expose the larynx. Second, we need to make empty to the larynx. And third, we need to make a proper passage of the umbilical tube. So the exposure of the larynx with video laryngoscopy has been well explained by Dr. Greenland by two cow theory. As we discussed, this is the primary cow, oropharyngeal laryngeal cow. This is the pharyngeal laryngeal tracheal that is secondary cow. So if you look at the, and this is the larynx. If you look at the meeting line between the primary cow and secondary cow, is in the vestibule, and meeting line is relatively straight. And if you are placing the camera over this line, and if camera is facing upward towards larynx, we get the image of the larynx. So that's the basic of video laryngoscopy. We need to place a camera at the meeting line between primary curve and secondary curve, and the camera should face towards larynx, and that's the reason we get the optimal laryngeal view with video laryngoscopy. So in short, if you look at in an imaginary video, this is the airway image with the video laryngoscopy in situ. So indirectly, with the video laryngoscopy, indirectly our eyesight is shifted into the pharynx, and from pharynx we take the image of the larynx. So line of vision with video laryngoscope is only this much yellow line, and because of only this much line of vision, it eliminates the need of three-axis alignment, and it eliminates the need of tissue, submandibular tissue compression. In short, video laryngoscope enables us to look beyond the curve of the tongue, as it enables to look beyond the curve of tongue. It provides a better protein visualization with the elimination of need of oropharyngeal axis alignment and tissue compression. That's the simple basic of video laryngoscopy. Now, there are a number of video laryngoscope. I think more than 27, 28 types of video laryngoscope are available in the market. What are the difference in this video laryngoscope? The difference with different video laryngoscope is the angle of the video laryngoscope. So if you look at the King Vision or Pentax or Artery type of video laryngoscope, so this is the, look at this, this is the primary curve. And if you look at the curve of King Vision and curve of Artery, is matched with the primary curve of the oropharynx. So it's anatomically curved blade. If you look at the CMAC D blade or Glasgow hyperangulated blade, the curve of these blades, again, as per the primary curve of the oropharyngeal laryngeal curve, that is primary curve, but it's more acute, more angulated. That's why it's called hyperangulated blade, but it's again anatomically curved blade. But if you look at the Macintosh type of blade, the curve of Macintosh type of blade, where it is in situ, is not matched with the primary curve of oropharynx. So it's a non-anatomically curved blade, or you can call it non-anatomical blade, Macintosh type of blade. So if you want to classify video laryngoscope, it can be classified anatomically curved, in which simple angulation, you can call it J-shaped angulation or hyperangulated blade. And non-anatomical curved blade is Macintosh type of video laryngoscope blade. So there are a lot of differences in the angulation of the blade. If you look at the Glasgow and CMAC D blade, it's more than 90-degree angle. But if you look at the Artery and Pentax or King Vision, it's having 90-degree angle. What does it make difference to us whether it's having 90-degree angle or more than 90-degree or hyperangulated blade? Higher the angle, camera where it is in situ, video laryngoscope in situ, camera is situated much nearer to larynx. And lower the angle, camera is situated much little bit away from the larynx. Look at this video. In circle video hyperangulated blade, camera is situated much nearer to larynx. J-shaped angulation blade, usually a little bit away from the larynx, and Macintosh is much away from the larynx. This is for a J-shape, and near the larynx usually is hyperangulated video laryngoscope. Now, what does it make difference to it whether camera is near to larynx or away from the larynx? When camera is near to larynx, we always get higher focus scoring and higher coronary angle volume 2. But it is when it is away from the larynx, camera is away from the larynx, we will get a panoramic view. So both are having advantage and disadvantage. Now, what's the position of camera and its clinical impact on laryngeal view, force of laryngoscopy, and laryngeal manipulation? So if you look at the J-shaped angulated video laryngoscopy blade, like King Vision or Artery or Pentax, so Here, it is anatomically curved but it is angulated. And it looks when camera in situ, the camera takes place in the pharynx like this, and it's looking straight. So, because it's looking straight, you'll get the view of the larynx, but many times you will not get the complete focus for your complete view of the larynx. To get the complete view, many of the times you need to lift the laryngoscope upward. So we'll get the panoramic view, it's looking straight, but you need to lift the laryngoscope upward to get the higher focus for it. However, there are chances of that epilodes can block the view. And little bit of force of laryngoscopy is required with this type of laryngoscope. But if you look at the hyperangulated blade, like similar D blade or Gleitstone hyperangulated blade, camera is situated and in the pharynx and angulated towards the larynx. So it's looking towards the larynx, underneath the epiglottis towards the larynx. And that's the reason most of the cases do not require force of laryngoscopy, and you will always get higher FOGO scoring. And for epiglottis, it's not possible to block the view with hyperangulated blade. But if you look at the Macintosh blade, when Macintosh blade in situ, camera takes place position here, and it's looking from upside down towards the line. So in this case, when you're using Macintosh type of blade, still you need to retract this tongue above the line of sight where it requires force of laryngoscopy, and epiglottic can block the view. And this requires higher force of laryngoscopy compared to angulated and hyperangulated blade. Now, if you look at the viewing angle of the camera, see, our eye is having our own perimeter. We are having our own perimeter. If you look beyond our perimeter, we need to change our neck position. Same way, each camera, video laryngoscopic camera, is having its own viewing angle, its own perimeter. That's called viewing angle of the camera. Suppose most of the video laryngoscopic camera is having 55 to 65 degrees. That is called narrow angle camera. When you are using narrow angle video laryngoscope, narrow angle camera video laryngoscope, if you want to look at the object, you will get the partial view of the object. To get the complete view, you need to withdraw the camera away from the object to get the complete view. That is the reason when you are using narrow angle camera for video laryngoscopy, you need to withdraw the laryngoscopic blade, video laryngoscopic blade, little bit away from the larynx to get the complete view of the larynx. But if you are using the wide angle camera, in spite of having your camera position near to the object, you will get the complete object view. Few of the companies are having wide angle camera. So this is the narrow angle camera, and this is the view. This is the wide angle camera, and this is wide angle view. So if you look at this video has been taken from the narrow angle camera. You will only get the view of the larynx here. And this view has been taken with the wide angle camera. Look at this is the larynx, and with the wide angle, you will be having adjacent structure also seen. So that is helpful in manipulation of tube, in manipulation of the scope, and in the ease of incision. if you try to, so and trachea is not a straight tube. So suppose this is a video laryngoscopy in situ. Look at the pressure of the endotracheal tube is as per the primary and secondary curve. So if you try to, so and trachea is not a straight tube. So suppose this is a video laryngoscopy in situ. So and trachea is not straight tube. This creates disparity of angle between blade and trachea. And because of this disparity of angle, it creates difficulty in pressure of the endotracheal tube. So if you try to pass this dilated tube, it's going to hit the anterior tracheal wall. So you need to withdraw the stylet and then advance the tube to facilitate intubation. Or you can use Parker flex tube or soft tube to facilitate intubation easily with the video laryngoscopy. So in short, hyperangulated video laryngoscopy require reshaping of the endotracheal tube. It requires anticoagulation. It's difficult to make anti to the larynx, which increase the time to intubate, and also there is a difficulty in pressure of the endotracheal tube. This problem has been sorted out with the different channel video laryngoscope. It's anatomically J-shaped video laryngoscope, but it's having side slot to load the channel. And this is one of the video taken from on the channel video laryngoscope. And because of this slide slot, the line, it makes the line of vision and line of insertion one. And because it makes the line of vision and line of insertion is same, you can easily intubate the patient with channel video laryngoscope. You don't require to have stylet. So, and keen vision or Pentax or Attract are such type of channel video laryngoscope. So it's a channel blade or hyperangulated video laryngoscope. The advantage is line of vision is same. Do not require stylet, require less time to intubate, and it's very easy to perform even awake intubation. This is one of the video laryngoscopic awake video laryngoscopic intubation in post-hemianoplectomy for D2 surgery. And this patient was given the bilateral superior laryngeal nerve block and transverse fluid along with the lubrication of the nose. And we could easily perform the mesotracheal intubation with non-channel blade of J-shaped video laryngoscope. And patient is fully away. It was performed under the cloth. If it is, patient is opening out, lifting up the head when asked to do so. So, channel video laryngoscopy is helpful in the obese patient also, and useful for the airway assessment in pre-op or even during the delivery in cases like the thyroid surgery or hereditary tumor to visualize the vocal cord. So simple clinical pulse of video laryngoscopy is very important. If you are expensive with the standard Macintosh laryngoscope, it does not mean that you are expert in a video laryngoscope. So experience with one type of video laryngoscope does not equate to the skill with all video laryngoscope. A good video laryngoscopic view of the vocal cord does not guarantee easy intubation. Movie may not be the solution when there is difficulty. Video laryngoscope chosen must be selected according to indication. Like if you use as a rescue device, then you should have anatomically curved blade. If you want to use as a routine practice, you should have Macintosh blade as well as anatomically curved blade. If you want to use in a predicted difficult area, then you should have anatomically curved blade. If you want to use in presence of blood, then you should have Macintosh type of blade. So these are about the curvature or angulation of video laryngoscopy and its clinical impact. And I think I am able to explain many things related to video laryngoscopy. Thank you.
Thanks, Dr. Apex, for this eloquent presentation on video laryngoscopes. Very informative, and actually you taught us very basic fundamentals of video laryngoscopy. Thank you so much. Over to our organizing secretary, Dr. Suma and Dr. Harish.
Thank you, Apex, and for your, as usual, very interesting presentation. Over to you, Dr. Harish.
Hello.
Hello, can
Hello.
hear you, Harish.
Yeah. Good evening, one and all. Myself, Dr. Harish, would like to thank the organizing committee of Nitte Anaesthesia Education Series for giving me this opportunity to deliver this vote of thanks. First of all, I would like to thank our Dr. Harish Raulapalli sir, Professor and Chief Cardiac Anesthesiologist, Narayana Medical College and Hospital, Nellore, who has taken time from his busy schedule to conduct today's masterclass on physiology of cardiopulmonary bypass. Thank you, sir, for conducting such an extensive and brilliant masterclass today. It was of much useful to us and everyone. I would also like to extend my heartfelt gratitude to Dr. Sanjay Bankal, sir, Senior Consultant Anesthesiologist, Narayana Hrudayalaya Institute of Medical Sciences, Bangalore, and Dr. Sharan Goda Patil, sir, Professor and Head, Department of Cardiac Anesthesia, JNMC, Belgaum, for moderating the case discussion on IHT, patient coming for CABG at this busy hour of the day. It was a very good discussion, sir. Actually, for us also, it was kind of very interesting and refreshing also. We could get very, very important points regarding many things that are usually happening on the cardiac side. Okay, I would like to thank you once again, sir. I would like to thank Dr. Apex Patwa, sir, Chief Consultant Anesthesiologist, Kailash Cancer Care Center, Muni Ashram, Vadodara, for conducting a wonderful lecture on video laryngoscope. It was a pleasure listening to you again, sir. Thank you very much, sir. I would also like to appreciate the postgraduates of KMC, Dr. Neha and Dr. Sisla Bhatt, who did a wonderful job at case presentation. I would also like to thank our audiences for waiting patiently and listening to all the talk that was going on. Today was a very good topic, and I think most of you must have got a very good knowledge from this session. I am grateful to Nitte University and our EDP department for their enormous cooperation in organizing this event. I would also like to thank all the faculty members of the Department of Anesthesiology of SHEMA who have worked hard for making this a successful event. Finally, I would like to thank our organizing secretary, Dr. Sumalata Madam, and our HOD, sir, Dr. Shripad Mandale, sir, who have been the backbone of this Nitte Anaesthesia Education Series and have made it a successful monthly event. So that okay. And lastly, I thank all those who have directly or indirectly helped us in making this educational series a successful event. Thank you all once again.
Thank you. Thank you, Harish, for your vote of thanks. Sipad sir, you already announced what is our next month's topic, no?
Yes.
I think you can re-announce it.
Please reiterate.
No, you do it again because people have changed, might have changed by now.
Yeah, we are having a discussion on electrophysiology and ECG. Then case discussion on a case patient coming for incidental surgery, having implanted a pacemaker, and then discussion on fiber optic bronchoscope. It's going to be a very interesting session again. I welcome everybody to the next event in the month of February, 3rd Thursday. Thank you so much. Thanks everyone. Thanks to Suma, Murali Shankar, Harish, all my faculty, postgraduates, participants, and all the resource persons today. Thanks everyone again.
Thank you. Thank you, sir.
Please provide your feedback at the link that has been given. You provide the feedback and before closing, otherwise you'll lose it. That's why. Thank you.
And you may also watch the presentation on
video
YouTube.
Online.
It is available online anytime. Thank you so much.
Ali, third person, Sharan Patil, bestie. Sharan department ಹೇಳಿದ್ದೇನಪ್ಪ?
ಹೌದೌದು.
ಅಸ್ ನೋಡ್ದೆ, ನಾ ಮನೆಗೆ ಬಂದೆ.
ಹೌದೌದು, ಎಲ್ಲೋಯ್ತದ?
ಆ?
ಎಲ್ಲೋಯ್ತದ? ಕಾಣಿಸ್ತಾ ಇಲ್ಲ ನನಗೆ.
ನಾನಾ? ಇದು ನಿನ್ ಸ್ಕ್ರೀನ್ ಅಲ್ಲಿ ನೋಡು.
ಓಕೆ, ಫೀಡ್ಬ್ಯಾಕ್ ಆಗ್ತಾ ಇದ್ದೀನಿ, ಆಮೇಲೆ ಮಾತಾಡ್ತೀನಿ.
ಓಕೆ.
ಓಕೆ, ಬಾಯ್.
ಬಾಯ್.
ಬಾಯ್.